morning.
This.
Oh, good morning, madam. Major Raja here.
Sir, welcome, sir. Welcome. Thank you very much for joining, sir. Sir, we don't
Very
have
nice
the
to see you.
privilege of seeing you, sir. We only hear your voice.
I say. I'll put it. Now we are able to see?
Not
Yes,
yet,
sir.
not yet.
Now?
No, sir. Yes, finally. Yes.
Huh?
Now we can see.
How are
Now
you,
it is
Mohan?
nice, sir. இதுவரைக்கும் மறைந்திருந்தே பார்க்கும் மர்மம் என்னவாதான் இருந்தது. இப்ப வந்துருச்சு.
I'm sorry, I'm not properly dressed now. I'm in only t-shirt.
No, sir. Major Rajesh, sir.
Hello, sir. Good evening. Mail, how are you?
Fine, thank you, sir.
Your house looks like a big museum and all this thing, lot of artifacts, everything with you.
Sir, my house,
ಅದೇ ಕಂಟಿನ್ಯೂಸ್
artifacts, all real things, sir.
Good, very good.
Dr. Rajesh. Selvaraj, please check in what name he is in. I think he is in the name Dr. P.B. Rajesh or Dr. Paula Rajesh. Please check. Vanakkam and good afternoon. Welcome to all of you to join us in this university webinar series. Success of healthcare is based on effective dissemination of knowledge and efficient exchange of information. With the causative organisms of several diseases crossing borders and the travel of mankind transcending distances, both dissemination of knowledge and exchange of information have gained greater significance. Of the many things that the COVID-19 pandemic has taught us, use of digital resources ranks the foremost. Assimilating all these facts in the appropriate perspective, the Tamil Nadu Dr. M.G.R. Medical University has embarked on a new journey this day, the 5th of March 2021. We start the university webinar series today. We propose to have this event once a fortnight on the first and third Fridays at 14:30 hours, 2:30 p.m. Indian Standard Time. Eminent medical and scientific men and women from various parts of the globe would be sharing their expertise and imparting their knowledge. All the affiliated institutions would be joining to participate in these webinars. On this launch day, I take great pleasure in welcoming Dr. Mailvahnan Natarajan, the 7th Vice Chancellor of this esteemed Tamil Nadu Dr. M.G.R. Medical University, who's here to launch this series. I also feel honored to welcome Professor Major Raja, who is also one of the former Vice Chancellors who had nurtured this university to what it is today. And as the Pitamaha in this meeting hall, we seek your blessings, sir, for effective continuance of this program. We have stalwarts from different parts of Tamil Nadu, especially people who were involved in COVID-19 management. Since we are right inside the pandemic, not yet out of it, the university thought it would be a fitting start to have this webinar series with topics related to COVID-19 pandemic this time. We have two main speakers, Professor Dr. N. Gopala Krishnan, Director of the Institute of Nephrology, Madras Medical College, who would be talking to us about the enigmatic facets of COVID-19 pandemic. We also have Dr. Paula Rajesh, the Vice President of the Royal College of Surgeons, Edinburgh, who would be giving us an overview of UK's response, reactions, and recovery with regard to the pandemic. Of course, as is customary in any medical meeting, we have stars shining all through. We have Dr. Mohan Viswanathan from Chennai, Dr. Ranjit Jayashekaran from Nagarkoil, Dr. Shantaram from Tirunelveli, Dr. Bhaktavachalam, again from Chennai, Dr. Ravi from Coimbatore, Dr. Ganapati from Erode, Dr. Chandrasekharan from Coimbatore, Dr. Sai Krishna Vittal from Chennai, Dr. Celestin Raj from the Karpagam Faculty of Medical Sciences, Coimbatore, Dr. Gerald from Madurai, and of course many others whose names, if I keep narrating, would probably extend for the next 120 minutes. I welcome each one of you wholeheartedly, and I sincerely wish this webinar series would effectively place us at an altar that we are able to exchange all the required information and be able to progress further in our chosen goals. Welcome to each one of you once again, and it is now my proud privilege to request Professor Dr. Mailvahana Natarajan to formally launch this webinar series. Thank you. Vanakkam.
Thank you.
You're muted, Mike. But unmute.
Yeah, is it okay?
Yes, sir. Great. Please.
Good afternoon. Vice Chancellor Dr. Sudha, my teacher, mentor Dr. Major Raja, my good friend Dr. Mohan Viswanathan, distinguished faculty, students and friends. Today is an important milestone in the academic history of this medical university, or our medical university. Digital technology has transformed the way we learn and share our experiences. As one of the largest health sciences university in India, it is appropriate that we are launching a webinar series to update and equip our faculty and students on the latest developments in the field of medicine. COVID-19 has thrown a lot of challenges in the field of education. In the medical field, the challenge is even greater. We have to rise up to the challenge and use technology that is available to fulfill the needs of the student community. Medical science is rapidly advancing. New diseases, development of new vaccines, changing therapeutics and management have to be taught to the present generation of healthcare providers. The new digital platform has paved a way for achieving this. The Tamil Nadu Dr. M.G.R. Medical University has well qualified and experienced alumni who are willing to give back to their alma mater. They can share their experiences and knowledge with the young and aspiring doctors through these webinars. In today's program, senior faculty from Chennai and Edinburgh are going to share their experiences in managing the COVID-19 pandemic. Academic programs conducted by our university are always well received and much appreciated. I am sure it will benefit the students and the teacher immensely. I am happy to note that it will be a regular series of events, and I wish the faculty and students all the best in their academic pursuits. I have great pleasure inaugurating and launching the webinar series. Thank you for inviting me here. Thank you.
Thank you very much, sir. We are honored. Rasiyana Kayyala, Rasiyana Todakam. Thank you very much, sir. And let me now invite Dr. Ranjit J. Shekaran, the chairperson of the J. Shekaran Hospital at Nagarkoil. The hospital had been doing yeoman service by admitting and treating COVID-19 patients during the pandemic. I would now request Dr. Ranjit to share his experience in the treatment of COVID-19 patients. Ranjit, the floor is yours.
Thank you for your nice words. I hope you can all hear me well.
Yes, Ranjit, please go on.
Yes. Anyway, good afternoon, ladies and gentlemen. So it's a privilege to be here among all the big people of our medical fraternity. So thank you for actually allowing me to be here. So first of all, I'd like to thank the Vice Chancellor of M.G.R, Dr. M.G.R Medical University, Dr. Sudha Seshan, and a team of other members of the university who organized this webinar, and it's going to be a series, I guess, from what we have been talking about. So, and thank you for inviting me and making me join this program as one of the initial speakers. So I'm Dr. Ranjit J. Shekaran from Nagarkoil, a small town from southern Tamil Nadu. Our hospital is part of Dr. J. Shekaran Medical Trust, and ours is a 250-bedded multi-specialty hospital, which is NABH accredited. So to talk about, when I got the message about what I had to talk about, so I was quite surprised, because, well, to talk about the experience in the management of COVID patients, it's going to be never ending, I guess, at this time. And yes, over the past so many months, we learned a lot, and we are still learning. To make it as actually an elaborate presentation about where we have learned and what we have learned and from whom we have learned, I try to make it as a very concise report rather than an elaborate presentation. So within this short period, I think I'm given about 5 to 6 minutes, so I guess I'll be able to finish. So April 2020, that is when the bell rang. So, and we were requested by the health authorities of our district and our district collector to be prepared for a probable pandemic of an unknown disease, which has originated from a distant place. Well, we blindly agreed to do our best and help, if there would be a need. But we never thought it will trickle down to small towns like ours anytime during that period. But however, we decided to be prepared. So during this time, there was so much of misinformation, information, facts, truth, like lies, which are actually floating down, everywhere actually, to every sect of the society. And among the public, it has caused major panic and apprehension and also suspicion. Well, during this time, we didn't have that many patients coming in, with COVID. But however, we were thinking back, looking back, we are seeing patients who appeared to be or who presented with symptoms and signs closely related to what we see today as COVID patients. Of course, we staying close to Kerala, we had so many of our patients coming in that time with various presentation, various odd presentation, which we think back could have been COVID. That's pre-April. Okay, and these are all the migrants who are returning either from Middle East or from Central Southern Europe or from the Eastern countries. So soon it was our time to act. So it was actually, the pressure was on us from the government. And that is when we realized that we were clueless about what we were to do. And we were totally underprepared. How underprepared we were then, though we were NABH accredited, we were part of actually like crisis management and also like disaster management. But we were never prepared for this kind of a thing. But we also realized everyone around the world was also in the same boat, you know. So that gave us the confidence. Then we said, okay, let's try to gather information, gather more facts, gather more things about what we could do, you know, just like the others. And of course, you know, like information from Europe was actually an eye-opener for us, and information from Singapore was also an eye-opener for us. So with the guidance of the senior doctors and also other clinicians from our hospital and some brave staff, I think I must thank them today on behalf of the institution, we could form good teams, you know, like very inspiring teams. And also, like, you know, we dedicated an entire block for the COVID care, and we did our best so that we could do our best to our patients. So this is actually, you know, our preparation for the care of the patients. Okay. From April 22 to 2020, our hospital has been treating COVID patients, asymptomatic, some highly symptomatic, and some very critically ill. Every day was challenging, and we decided to remain steadfast and do what was possible with our limited resources. However, like things kind of actually like settled down over time, and we knew that we could, with what we could gather from, you know, like the information as well as the input from other sources and also the guidelines and protocols, we could do something for our patients. We had 100 dedicated beds for COVID positive patients with about 40 oxygen supported beds. We had 14 ICU beds with ventilators, NIV, and high flow nasal oxygen support. And we also had a large step down ICU where, you know, we had to treat most of our patients that time itself. Most of these beds were occupied during the peak period. That's August, September, and October. Like most of you people would have experienced that time. And definitely that is when it was very tough and stressful. So this was honestly the genuine experience which we went through. There were so many guidelines and protocols which were put forth for the management of COVID patients, as we are all aware of. And it was every week or every month or every day. And it was changing. It was only to be changed the next week. So we decided to follow certain guidelines suggested by certain knowledgeable groups. One was Madras Medical College, you know, when they had brought out their protocols of initiating these patients on steroids, which we decided to do so. Christian Medical College, Vellore, AIMS, Delhi, and also from certain other very reputed institutions from around the world. With all this input, we created our own protocols, we created our own guidelines, and we started treating our patients. Anything which did not appear to be scientifically supported by evidence was not encouraged, and it was definitely not followed by our institution. For this reason, because we got into trouble a couple of times, anyway, like it's all in the past. There was one thing that was understood by all, especially, you know, our local health sector department, the officials, the media, the public, and finally the medical professional, that this pandemic was to be accepted as a dangerous viral disease. and managed accordingly too, and not to be feared as an act of demons. So this took a while actually to change, and especially in a small town like Nagarkoil, it took a very, very long time. Thankfully, it has happened, and well, things have changed. Our center has treated about 1,200 COVID patients in the last 10 months, and in spite of all our efforts, we lost 52 patients till last week. Sadly so. The most of the patients whom we lost were in the initial phase of our our attempt to treat these patients, that is still August and September. Meanwhile, we also had to manage an equal number of patients with COVID-like syndrome who are RT-PCR negative. Later, their death rate was also equal. And looking back, we also feel that it would have been COVID. If only we had actually screened them again and again, probably we would have had actually the diagnosis. So the treatment protocol was based on the severity of the disease in our institution. The asymptomatic were managed, like in separate wards. The mild to critically ill were, managed in the area of high dependency, and that too in this COVID dedicated ward, and they were treated accordingly as per the protocols. The earlier they presented to the hospital, the better was the outcome with less complications, as you all agree. And most of them, they were referred to, say, us kind of almost like a semi-referral hospital. Most of them were referred to a hospital at a much later date when they had established all the complications and they were in the point of no return. So that is when we lost, in the initial phase, a lot of patients. They were managed with symptomatic treatment. Of course, everyone needed that. And supplements was a very important thing which we believed on. A proper nutrition was initiated, from the time they were admitted. Fluid management was actually the mainstay. Antivirals were given to appropriate patients. Antibiotics, when there is a probable chance of getting a secondary infection or evidence of a secondary infection was noted, or if the disease was very severe. Steroids were initiated in most of the patients who presented with high inflammatory markers. And anticoagulants was given to almost all the patients, after the initial advice from the semi-formal. Antifungals in selected patients, and a few of our cases received monoclonal antibody therapy. And that depended on the severity, and also we didn't go by the interleukin alone. We went by the severity, the high ferritin index, and also the high CRP level. And also the quantum of inflammation which the person was actually subjected to. All these patients and the family members received counseling every day. We had a team of people doing primarily counseling, keeping them well informed, keeping them in good humor, cheer. So that really helped us. In fact, the support of the family members was throughout, as the patients recovered or they underwent the treatment and they recovered in the hospital. Oxygen was needed in many patients, and of course the mainstay even after discharge, where there are still many patients continuing to have oxygen therapy. Breathing exercises and proning did help, in fact, that is one early information which we had. So we did try to prone most of our patients with ventilation or without ventilation, with NIV or with high flow nasal oxygen. And they all did fairly better than people who could not prone themselves. Post-discharge treatment protocol was also created by our institution and was advised to everyone. And the follow-up was suggested as many patients who were discharged developed complications, unexpected complications, unrecorded complications later, and they needed readmission. So with this few words, I think I'll pass on actually the real topic to be handled by experts who are going to follow that. So thank you very much. And thank you very much for your patient hearing.
Thank you, Dr. Ranjit. Thank you very much. That was a very lucid overview of what was happening at the southern tip of this land. I would now call
Thank you very
upon
much.
Dr. Shantaram, Professor of Pathology, Tirunelveli Medical College. Dr. Shantaram would be introducing the first main speaker of the day, Professor Gopala Krishnan. I would also request Dr. Shantaram, he being a pathologist, if he could just say 1 or 2 lines on what had been really the picture in relation to the COVID pandemic, and also a request to all those in the meeting hall, if you have any questions or opinions, kindly type them in the chat. The questions that you would want to ask, kindly type them in the chat screen. Those questions will be taken up by a team which is sitting here, and appropriate questions would be submitted to the speakers for further interaction. Dr. Shantaram, please.
Good morning, madam. And am I audible there?
Yes, sir. Please go on.
I thank the university, especially our Vice Chancellor, for giving me this opportunity. I am Dr. Shantaraman. I am the Vice Principal, Tirunelveli Medical College presently, and a Professor of Pathology. To make things, before I introduce Professor Gopala Krishna, as requested by our Vice Chancellor, I would try to make a few underlines on what our personal experience was with COVID in terms of laboratory and genomic diagnosis. I think we had our first case in March 21. And to date, we have almost admitted more than 5,500 patients, and we have had a very good recovery rate. During the process of almost 6 to 9 months, I think Professor Gopala Krishnan would also agree with me. Government hospitals in this state were the mainstay of treatment and recovery during the entire pandemic. And it was a lifetime experience, because when I started my profession, I had not heard or learned anything about such a pandemic. So everything what we did every day in the morning was not out of our textbooks or reference, but it was out of patients and patient experience. The best thing that we learned in this entire pandemic was that we could ramp up our capacities within periods as short as 10 days to 40 days. We ramped up our bed strengths, oxygen supply, the capacities of ventilation, capacities of high flow, and more wonderfully, it was the capacity to diagnose. From a small viral laboratory which was doing 5 to 10 tests a day, we ramped up to doing PCR for 2,500 to 3,000 patients a day, putting up a turnaround time of 4 to 6 hours in max. That was, I think, the best learning point. Then finally, from what one line I'd like to underline was our experience with genomic diagnosis of COVID. Way back in October, even before the national advisory on genomic analysis of COVID virus started off, we in Tirunelveli Medical College, with the assistance of CSIR, had the experience of sequencing the viruses in our place. It was wonderful to understand that the phylogenetic pathway was documented so interestingly that we could tell from where the virus had originated and traveled to each part of this district. And possibly even the phylogenetic pathways were so well made out during the process of the sequencing, that we could even say where the virulent strains were and the less virulent strains were. And when we started off in April, we had the A3I genomic strain that was prevalent in this part of our district, or this state. With the progression, slowly we converted to an A2A genome, and probably I think our viruses are still mutating. I think we have undergone more than 18 mutations in the last 9 months. So this experience is what I would like to underline, because our speakers are there following us. So I would go on to introduce Professor Gopala Krishna on this. I am proud to introduce Professor Gopala Krishna, who is a good friend of mine. He was born in June 1964, and he holds a MD in General Medicine and a DM in Nephrology, an MRCP and an FRCP from London. He is currently the Director and Professor, the Institute of Nephrology, Madras Medical College and Rajiv Gandhi Government General Hospital, Chennai. He has been responsible for initiating the deceased donor renal transplantation programs from the Kirpak Medical College as well as the Rajiv Gandhi General Hospital. And he was also responsible for establishing the maintenance dialysis program and the CAPD program at the Rajiv Gandhi Government General Hospital, and was importantly involved in the establishment of low-cost dialysis units in the suburbs of Chennai, especially in Avadi, Kolattur and Red Hills. As the current Director and Professor of the Institute of Nephrology, he has involved in 700 plus renal transplants and has trained more than 60 nephrologists till date. Beyond all his official positions, he is also the member secretary of the Institutional Ethics Committee at the Madras Medical College, also the special officer for postgraduate affairs and a nodal officer for COVID activities at the RGGH, and that is why he is speaking with us today. He is an active contributor to the functioning of the Tamil Nadu Dr. M.G.R. Medical University as a member of the Board of Studies for Research since 2013, member of the Board of Studies for Higher Specialties from 2013 to 16, a member of the Scientific Research Committee since 2020, and he is also a member of the Hospital Standing Committee for AIIMS New Delhi. He is an expert committee member for the Indian Society of Nephrology Southern Chapter, Scientific Committee member of the Peritoneal Dialysis Society of India, the Indian Society of Nephrology, Indian Society of Organ Transplantation, and also a core committee member of the International Society of Nephrology, American Nephrologists of India origin, and a board member of the South Asia Regional Board of the International Society of Nephrology. He holds a fellowship with the Indian Society of Nephrology. He is a core committee member for chronic kidney diseases in the Indian Council of Medical Research, ICMR. He has been an expert committee member in formulating the standard treatment workflows under the Ministry of Health and Family Welfare, New Delhi, and he is recipient for several honors and awards, of which a few of them I would like to read is the J.M. Patel Oration Award, Sam G.P. Moses Oration Award, the Professor M.S.R. Oration Award, APJ Abdul Kalam Oration Award, Devasagayam Oration Award, the Chaco Jacob Oration Award of the Christian Medical College. He is also recipient of the Lifetime Achievement Award from the Tanker Foundation, the Best Doctor Award with the Ministry of Health, Government of Tamil Nadu.
Please go on.
Am I audible?
Yes, Dr. Shantaram, please continue.
Yes.
Hello?
Yeah, you are
Please
audible, sir.
continue, Dr. Shantaram. Please continue.
Yeah. And also he had a Best Doctor Award and Award for Extraordinary Contribution for Transplantation from the Government of Tamil Nadu. He holds authorship for 110 publications and has authored 17 chapters in books. I think at the end of the day, I would be very tired if I need to complete reading the entire curriculum vitae of Professor Gopala Krishna. I have only one thing to say. He is the best person in our health system today to talk to us about COVID-19, because he has been in the hem of affairs of Rajiv Gandhi General Hospital, which has been the forerunner of COVID pandemic management in terms of both tertiary care as well as giving us guidelines to the other hospitals in the state. So welcome, Gopala Krishnan sir, please.
Thank you, Dr. Shantaram. Before I request Professor Gopala Krishnan to speak, I know I'm intruding, but then this is on a very, very happy note. Let us all wish Professor Gopala Krishnan a very, very happy wedding anniversary. We wish you years and years of joyous togetherness, sir. And this is a classic example of duty taking precedence over everything else. Thank you very much, sir. Please continue. This is your floor.
Very good afternoon to one and all. Respected Vice Chancellor of this esteemed university, all the faculty and professors of this university, and all the learned persons, senior professors, and friends who have gathered virtually to attend this conference. I consider this as a kind of a privilege and pleasure to present my limited experience in COVID pandemic. I've been allotted 30 minutes. I was really at loss how to design my talk because, it has, as I have the title, this enigmatic COVID has got multiple phases. To talk about every phase that itself will take hours and hours of time. So pardon me if my lecture sounds a bit discontinuous and hopping from one area to another. What I've decided is that just to highlight on certain phenomena which really perplexed, which really kind of kindled our interest and enthusiasm and where we stumbled and so on. So heaps of good wishes from the great Madras Medical College. What you see here is the Red Fort. I never considered this pandemic as is all about a disease caused by one particular bug. No, it is a war in disguise. Why do I say that? This disease has totally changed the entire world topsy-turvy, be it economically or politically or socially, at individual level and country level and continent level. And the emotional perturbations it has caused, the psychological impact it has already inflicted upon. And it is going to be there for quite some time. And I am sure that, we all have reached a kind of a new normal, and all our life's proceedings here afterwards is going to be described as pre-COVID and post-COVID. So can just one disease cause all this? It is a war that has been thrust upon the humanity. So, and again, most of the wars have a definite purpose, and most of the wars, what kind of enemy you are fighting with, and what are the real dimensions and positives and negatives of the enemy you are going to fight, and so it becomes rather easy to strategize. But here we dealt with an enemy whose dimensions and magnitude was just evolving. We were just clueless as it struck on us. Fine. A quick recapitulation of the basics of the COVID virus, and then we'll move on. As you can see here, this is a very familiar picture by now, and it may not require a greater explanation, but still I would start that way. It is an RNA virus. As you can see here, there are multiple spikes on that viral body, and this is called S protein that gets stuck onto the receptor, which is expressed on the cell surface, which is nothing but angiotensin converting enzyme 2. What is peculiar is that this angiotensin converting enzyme 2 receptor is expressed in a host of tissues and organs. But the puzzle number 1 starts here. Why? The lung is the most significantly affected. Why not others? For instance, the density of this ACE2 receptor is as equivalent to lung in the kidney itself. Even though we do have acute kidney injury and kidney dysfunction, kidney failure is not that common as lung. Like that, there are a host of tissues where you have this receptor, but still lung seems to be the most dominant organ that is getting affected. There are many reasons. Now we know little bit of it. Why is it not happening? Number one, the receptor population. The more the number of receptors, the particular organ becomes more vulnerable. And it is not just that. The spike protein, after it gets bound to the receptor, it has to get activated by something called a transmembrane protease serine 2. Even if a particular tissue has a receptor, if this mechanism is not there, this binding will not be successful. So this is one explanation for that. Okay. And as you can see here, what happens next is that once this ACE2 is occupied and the virus enters into the cell, subsequently there is down regulation of angiotensin converting enzyme 2. Please remember, in simple lay language, ACE mediated pathway is injurious. ACE, the products are angiotensin 2. Angiotensin 2 mediates multiple injurious mechanisms. On the other hand, there is a nice balance of taking the other pathway through the angiotensin converting enzyme 2. That results in a set of molecules which are antifibrotic and anti-inflammatory and antioxidant, and that causes vasodilation and so on. But here, this treacherous virus occupies the ACE2, invades into the cell. Following that, ACE2 is down-regulated. Here comes the pathogenesis. Fine. Then what happens? There are so many people who get affected, but not everybody goes in for a dismal prognosis. The case fatality rate is fortunately very, very good, very, very low compared to so many other viruses. The mortality rate is much less. But why? What decides? In the same family, we do see the same quantum of infection, but the outcome is different in different people. Here comes the trick. It is not just the virus potency, it is not just the potential of the virus to invade our system. What decides the further course of events is how the host responds to the virus. So the response of the host has got multiple determinants, including genetic susceptibility. As you can see here, this is a very complicated diagram, but you just see what all the things that do happen after the virus enters into the host. The host's response is multi-directional, resulting in some unfortunate people what is called a cytokine storm. Cytokines are nothing but molecules which are friendly, which are important for normal physiology as well. But anything in excess becomes an injurious agent. The most important being interleukin 1 beta, interleukin 6, interleukin 10, and TNF alpha, and so on. So many things. On the other hand, there are activation of the oxidative enzymes, and so it becomes a kind of an oxidative injury. Okay. So there are multiple mechanisms of the tissue injury. The most important being the inflammation mediated by the cytokines, and then activation of the oxidative enzymes. And the third most important thing is the thrombosis, the microthrombosis happening in multiple organ systems. That's what we learned, a beautiful lesson we learned. So this is a depiction of what happens in the different phases. One is the viral response phase, that is the early infection phase, where the mild constitutional symptoms will be there, dry cough, diarrhea, and headache, and so on. Second phase is the pulmonary phase, where you have the shortness of breath and hypoxia. And third phase is your hyperinflammation phase, that results in the deleterious consequences like ARDS and shock and cardiac failure and so on. So here, as the first presenter pointed out, those who land into a kind of a medical care providing system early in the first phase, they escape because they are under constant monitoring. We know what to do and how to do it all. Whereas many people, initially, they hesitated to come to the hospital and they were self-medicating and so on. By the time they reach, already they are in the host inflammatory response and huge elevations of the inflammatory markers and so on. In such subset of patients only we had serious problems and so on. See, each phase of the patient's clinical illness requires different kind of medical approach. In the early phase, it is very diligent monitoring and symptomatic management only. Whereas as the phase advances, particularly there is kind of hyperinflammation, you need to subdue the inflammation with corticosteroids. And we tried even with tocilizumab, IL-6 antagonist and so on. And the treatment was very, very tricky. Initially, we all started with oseltamivir. We didn't know what to do. And then hydroxychloroquine and so on. We kept on increasing our ventilator availability and so on. But fortunately, there was a lag time between what happened in Italy and Spain, and then the pandemic started here. During those 2 initial months, we learned a lot. Initially, there was huge mortality in Italy because they thought it is like yet another viral pneumonia. It's a kind of a pneumonic process. And pneumonic, they thought it is a pneumonic consolidation and then ARDS, so mechanical ventilation is important. But this mechanical ventilation per se can cause a lot of problems. That per se can worsen the cytokine storm. And the autopsy series of the Italian initial month series, it revolved a very surprising pathology, that is a microvascular thrombosis. That opened our knowledge in the sense that the more important drug rather than mechanical ventilation is your heparin, oxygen. So to overcome this microvascular thrombosis, to overcome the ventilation perfusion mismatch, you have to give so much of oxygen, high flow nasal catheter with which you can give even up to 50 liters of oxygen per minute with non-invasively. That was a great learning. So we started capacity building on that way. So as Professor Shantaram highlighted, this disease posed human challenges enormously, and we realized that there is so much of hidden potential in all of us. And again, this pandemic taught us very important lessons, that individual is never important, it is always a teamwork. And again we learned that we all sat together and we in fact ditto the same sentence, we kept on repeating each other, that this is one time at least we have to forget about subspecialties. We are all basically medical care providers. Let us all join hands and function as one team. Let us forget whether I'm a physician or a surgeon, an orthopedician, an anatomist or microbiologist and so on. Why? Because the surge of patients was so much, enormous, no particular department can handle. Initially, people thought that it's only internal medicine, thoracic medicine, and anesthesia. These 3 departments will be able to handle it. But it was a mammoth proportion. So starting from the basic sciences and paraclinical sciences and preclinical sciences and clinical sciences and subspecialties, all of us had to do duty. And all of us, for once, forget our specialization of subjects. Fine. What happens next is that once the pro-inflammatory phase is happening, then the body reacts in a nice way. It initiates the anti-inflammatory response as well. There has to be a beautiful balance, and then the patient recovers. If there is a tilted balance more towards inflammatory phase, those patients didn't do well. This is another important thing. As I've already said, why some people escape with just mild disease. This is a nice paper. They have demonstrated there is genetic polymorphisms in the angiotensin converting enzyme. 2, there are certain variants where there is increased susceptibility, and in certain variants, the susceptibility is much less. Okay. And before moving ahead further, as a nephrologist, we had special interest. What is the impact of this COVID on kidney disease? What is the impact of pre-existing kidney disease on COVID? Both had actually is kind of a real problems. And this is a paper which shows that incidence of acute kidney injury can happen in COVID due to multiple mechanisms. the incidence quoted as high as 30% in some centers and so on. We also had such a situation. And the presence of acute kidney injury, occurrence of acute kidney injury, it was an independent negative determinant of the outcome. There are multiple mechanisms how acute kidney injury happens: macrophage activation and inflammation, activation of coagulation, thrombosis, oxidative stress, and so on. Interestingly, the virus itself can invade the kidney, and there are specific pathologies like collapsing glomerulopathy has been demonstrated. Fine. And the worst subset of patients who suffered to a greater extent is that those who had mild chronic kidney disease, after they got this COVID infection, there was a rapid worsening of the chronic kidney disease, most of them even warranting initiation of dialysis. Most of them, they didn't do well. Why I talk at length about kidney disease is that look at the difference in mortality in those with normal creatinine and those with higher creatinine. So the presence of renal failure made a significant difference, a negative difference in the outcome. Fine. As you can see here, the association of kidney disease with in-hospital mortality. Uniformly, the odds ratios, they reveal that presence of kidney disease was a negative determinant. Then quickly I'll run through our experience in GH. We could mobilize 1,618 beds. Our dean, as a dynamic team leader, we recruited all of us and we assigned the responsibilities, formulated multiple teams, and each team will have a subhead, and under each subhead there will be a group of people and so on. And the 4-tier system we evolved. 4-tier system meaning we had different blocks, COVID blocks were assigned. Initially we started with just 10 beds. We kept on increasing the number of beds. 1,618 was at the peak time, out of which about 450 were ICU beds. So far we have treated more than 30,000 patients. Fine. What we decided is that cutting across specialties, everybody will be, the junior doctors will be at the front line, and then there'll be an assistant professor, and for each block of building will function autonomously with a facility in charge, who is a senior professor usually belonging to surgery or surgery specialties. And then the treatment in charge will be a physician or a medical allied specialist, and there will be a continuous, seamless, multi-directional flow of information among all these 4 tiers of personnel in each block. And each block's data will be collated at the dean's chamber and that will be reviewed. So that worked so well, and for the first time in life we realized the importance of having the mobile phones, and the Android phone was given to each ward, and in that mobile phone itself all the lab reports will be given, even the radiology reports will be given, RT-PCR reports will be given. So, and there will be a kind of a data collation center in each block. It worked so well. It was almost like working at the war front. Fine. So this is not really updated. After November, still we have about 100 patients, but the number of patients is progressively coming down. So this is what is that? The death was about 5.42% mortality, and there was a male preponderance. About 2/3 were males. And this, as you can see, the trend of admissions, July and August were the worst month for us. It was really nightmarish experience. And the, as I've already said, fortunately, majority of the patients were asymptomatic, 83.5%, only 16.4% was symptomatic. Here comes the importance of comorbidities. Who didn't do well? Morbid obesity, diabetes, hypertension, coronary artery disease, bronchial asthma and chronic lung disease, chronic kidney disease, and hypothyroidism and so on. The most important being diabetes. Diabetes and COVID. There is so much to discuss. On the one hand, diabetics are more vulnerable to develop COVID and the COVID-related complications, and mortality is more. On the other hand, there is a huge worsening of glycemic status after they got the COVID infection because of multiple reasons. One, the steroid is a mainstay of therapy that increases hyperglycemia. The emotional stress also played a small sport. The third most important mechanism is that we learned that the virus invades the pancreatic beta islet cells itself. So the virus per se is diabetogenic. Many people develop new onset of diabetes after they developed COVID infection. So then there was a daily death audit. That was another innovation of our dean. 3 professors will be just going through in greater detail the mortality case sheets of the previous day. We found out 2 important determinants were contributing for mortality. One was that dysglycemia, the sky high levels of diabetes. Even though physicians were managing in So we felt that there has to be specific focus for that. So we identified one nodal point for management of the blood sugar alone in each block. That really paid rich dividends. The other one was dyselectrolytemia. Many people developed hypernatremia because you'll be giving all that, the oxygen and all these things, but they will not be drinking water, they'll not be having enough food. So hypernatremia was a problem. And then hyponatremia, because the virus can cause syndrome of inappropriate ADH. So we identified one nodal point exclusively for looking into electrolytes for each block that really paid rich dividends. So this is the monthly trend of case fatality rate, as you can see here. Yeah, this point again I would like to highlight. See, this virus was kind towards children and young people, and the mortality increased as the age advances. As the age advanced, it was more than 50 and more than 60 years, they were at a high risk for poor outcome. And this slide again highlights the importance of comorbidity in terms of the outcome. Those who had comorbidity, the death rate was higher, particularly diabetes and hypertension and so on. We had special challenges in nephrology. So what happened initially, there was a panic and fear across the society, and all the private centers, even if one patient on maintenance dialysis unit turned positive, they shut the entire unit and they simply referred the patient to Government General Hospital, MMC. We couldn't say no to any patient who's about to get dialysis, but the dialysis center has shut the doors. We started getting patients like this from 75 different centers from across the districts and so on. There was a huge crisis. And our own dialysis staff, they ran away out of fear. Thanks to my team, my dedicated postgraduates and my assistant professors, they themselves performed dialysis for 3 consecutive days, day and night. So far, we have handled about 720 patients with COVID positivity. This is the highest number in single center in the entire country. So it was a huge challenge because you have to have a dedicated dialysis unit. So we identified one dialysis unit with 10 machines and then 2 machines in each and other 2 blocks. So totally 14 dialysis machines were dedicated for handling COVID positive patients and so on. And these are some of the strategies our institution, under the dynamic leadership of our dean, we initiated exclusive outpatient department with 0 delay ward, meaning many patients, they sit at home until they develop symptoms. So we have established a 0 delay ward where at the OPD itself, if the patient comes in a state of breathlessness, immediately he'll be attended to, including CPAP at admission point itself. And then we also popularized one mobile number through AIR and other media, so that anybody starting at home can call us. So that also really helped initially. And then WhatsApp group or different blocks, and battery operated ambulance car to take the patients to different blocks, and standardized management protocol. That was a very crucial step, and it was a defining moment of the entire COVID care, so that every doctor, even just newly joined first year student of any specialty, was empowered to handle the patient. He or she need not be waiting for getting instruction from the next tier. So what we did, we prepared the standardized treatment protocol based on mild, moderate and severe category, and then created big flux boards, and the flux boards were affixed in every ward. So that gave kind of the encouragement and boldness for the junior doctors at the this thing. And then we prepared customized case sheets so that all data are filled in. About 56 research papers have evolved from the experience from all these specialties. This is because of the customized case sheets and so on. And then this virus is very, very peculiar in the sense that it does not cause just physical illness, but also it causes kind of a psychotic disturbances. Probably it invades the portions of the brain like limbic system, which handles emotions and so on. There are any number of instances of very severe depression, anxiety, insomnia, restlessness, even committing suicide and so on. So what we did is that a team of psychiatrists, they kept on talking to every inpatient every day, those who are in a position to talk, and they will alert us, such and such patient is in distress, immediately go and attend, start on antidepressant and so on. So far 7,800 patients were counseled that way, and the final data is emerging on how many of them had really depression. Fine. The treatment, as I said, all the treatment modalities which we started, initially everything was looking promising. But when all the data were put into kind of a real scientific format, most of these therapeutic measures found to be rather ineffective. They failed to assume the statistical significance. But the very peculiar point is that you can't set aside just because you are not able to achieve and demonstrate a scientifically significant difference in the outcome of by one particular intervention. You can't simply set aside saying that that maneuver is useless. Why I'm saying that? Because the standardized protocol can just function as a kind of a basic fulcrum for management. Each disease, each patient has to be approached in a completely specialized way, taking into account all factors. So a particular drug or maneuver which has not been shown to be effective in a particular trial can be really life-saving in a particular patient. It all depends on the timing and selecting the patient. For instance, MMC was one of the first two institutions which were given permission to start plasma bank, convalescent plasma, MMC and All India Institute of Medical Sciences. Even though among renal patients we found it extremely useful, the overall experience when it was put into kind of a scientific format, it didn't fetch good result. Same thing with tocilizumab, IL-6 antagonist. So I can vouch and say that some people really recovered well following timely administration of that, but overall again it didn't reach significance. The greatest disappointment was with the remdesivir. There was one study, WHO initiated, ICMR conducted solidarity trial. MMC was part of it. Our dean was the principal investigator. I am one of the co-investigators, co-primary investigators. It was studying the different maneuverings with remdesivir or hexaquivers and lopinavir, ritonavir combination, interferon beta and all that. But the result is disappointing that it was a kind of an intercontinental multicentric study, 30 countries with 405 hospitals, 11,000 and odd patients. The 28-day mortality was 12%. The conclusion was that none of the drugs had significant effect on overall mortality or initiation of ventilation or duration of hospital stay of hospitalized COVID-19 patients. So that's it. So, so the enigma continues and the challenges continue. Be it, but one thing I'm sure that we are very, it has been a kind of a very gratifying experience in the sense that the human resource augmentation, the capacity building, ability to strategize newer interventions and newer modalities of approach, and more than anything, establishing a kind of a card of camaraderie among all the people, about 2,500 medical personnel in one institution, everybody joining hands and trying to face this single treacherous bug. It was a beautiful journey, even though it was stressful. It was really gratifying. We were able to achieve a very good success rate and recovery rate, and our mortality now, as of now, is less than 4% overall. But the story doesn't end here. We don't know whether the pandemic is really over. Even today, we have about 97 positive patients. Some of them are really sick. That's number one. Number two, after the recovery also, the post-COVID sequelae. And MMC is the first in the entire country to start a comprehensive post-COVID follow-up clinic where we look for specifically the psychiatric disturbances, anxiety and insomnia and so on. Number one, new onset COVID, new onset diabetes, then lung fibrosis and thrombophilic phenomena and complications and so on. And now vaccination is going on in full swing. Again, it's a big challenge. Initially there was a lot of hesitancy, and now the people are coming forward to get the vaccination and so on. So it was a kind of a comprehensive journey, starting from prevention, taking care of the disease and managing the complications and anticipating the complications, strategizing, and then taking care of post-COVID sequelae as well. Thank you so much.
Very informative and educating. Before we proceed with interaction and questions, we would also hear Dr. Paula Rajesh. So let me now request Dr. Bhaktavachalam, Professor of Vascular Surgery at the Tamil Nadu Multi Super Specialty Hospital to introduce Professor Dr. Paula Rajesh, the Vice President of the Royal College of Surgeons, Edinburgh. Dr. Bhaktavachalam, please. Dr. Bhakta, are you there? Yeah, please unmute yourself, Dr. Bhakta.
Madam, are you able to hear?
Yeah, yes, please proceed.
Thank you, madam. First, I like to thank Vice Chancellor for giving me the opportunity to introduce and also is a part of this webinar. I'd like to introduce a great MMCN, Dr. Paula Rajesh. Before introducing him, I'd like to highlight some important, BC has given me a permission to highlight a few important points that COVID-19 affecting our vascular system. The mortality rate of COVID-19 is 3.4% among all the patients, for which 1.4% without any underlying disease, of which 13.2 were having pre-existing cardiovascular disease. The elevated D-dimer level were the independent predictor of the mortality. 71% of the patients who died were diagnosed with the disseminated intravascular coagulation. A study reported high incidence of venous thromboembolism in ICU patients, that is 69% are having this, despite prophylactic anticoagulation. 31% of which developed VTE and 16.7% pulmonary embolism. Pulmonary embolism was more likely to occur in acute respiratory distress syndrome. The COVID-19 introduced a deterioration of coexisting cardiovascular disease. My department in the Tamil Nadu government multi-super specialty hospital not closed on a single day during the pandemic period. We are able to do, our census are more than the pre-COVID period. Now, it's with a great pleasure I'd like to introduce Professor Paula Rajesh. He is qualified from Madras Medical College in 1974. Really, I am proud to say that he is an alumni of Madras Medical College. He was trained in the UK in general surgery and obtained FRCS Edinburgh in 1982. Paula's cardiothoracic training continued between Hull and Sheffield and obtained his FRCS Edinburgh cardiothoracic surgery in 1994. In May 1995, he was appointed as a consultant thoracic surgeon in Birmingham. He is a senior consultant thoracic surgeon. Recently, he retired from Birmingham Heartland Hospital of UK. Currently, he is the president of Royal College of Surgeons, Edinburgh, first ever person of Indian origin to occupy this high post. We Indians are really proud of this. Thank you, madam. He is going to speak about UK's response, reaction, and recovery to COVID-19 pandemic. Thank you, sir.
Dr. Rajesh, the floor is yours. Welcome.
Thank you. Thank you very much for the kind words, Professor Bhaktavachalam. It is a great pleasure and an honor to be invited to participate in this August gathering this morning. Morning in the UK, but afternoon in India. Sudha, I want to thank you personally for allowing me to participate this afternoon and to share what has been our experience in the United Kingdom in this really unprecedented crisis which was across the globe. We went into lockdown in March of 2020. The preparations which were made in the United Kingdom was probably slightly delayed when we knew that this tsunami was going to hit us from Europe. I'm going to share my screen now, and I hope um, that I'm successful in doing so. Can you see my screen yet?
Something appears to be coming in. Yes, yes, it's come, it's arrived.
Thank you very much. So, what was the UK government's response as soon as we knew that Europe was affected? Um, so the UK government response was to stay at home, to protect the NHS, which is the National Health Service, and to save lives. This was our Prime Minister Boris Johnson's initial plea to the public. Reason to stay at home was to prevent transmission. The reason to protect the NHS was not to overwhelm the admissions to the hospitals, and as a result, save lives. The country went into lockdown in the latter half of March, and the NHS preparation went into an overdrive. Public Health England, with SAGE, which is the Specialist Advisory Group on Emergencies, was formulated, and daily bulletins were published every afternoon by the Chief Medical Officer, the scientific advisors, and the ministers on national television. There was a rapid training for deployed staff. As I heard from the previous speaker, the fact that we are all trained doctors meant that we needed to deploy to the front line. The trainee workforce were rapidly taken away from a variety of arenas, especially from the research and the out-of-program experience areas, back into the front line. The consultant workforce were also deployed, i.e., people who were uncomfortable in clinical areas, the radiologists, the pathologists, the microbiologists, the dermatologists, and a variety of medical specialties who were not used to the accident and emergency department, the intensive care departments, and in the frontline medical wards. So a very quick training, rapid training was created, and the deployment was done within weeks. We then had a procurement crisis. This, if you like, was political. We were not prepared yet to undergo any response to a pandemic. So the procurement crisis with the PPE and the FFP masks was quite bad at that time. So what did we do as a surgical group in the United Kingdom? The joint surgical colleges, of which there are 4 in the UK, which are in England, Scotland, both the Royal College of Surgeons of Edinburgh and the Royal College of Surgeons of Glasgow, and the Royal College of Surgeons of Ireland. And then we have the 11 surgical specialty associations. All of them, alongside NHS England, the Federation of Surgical Specialty Associations, put together guidelines. And the most important prescription was the use of personal protective equipment to all healthcare personnel. This was applied to the ward area, the admission area, the endoscopy theaters, and in the operative theatre and the intensive care units. The non-essential surgery was immediately stopped. Emergency surgery, the acute surgery, and the urgent planned surgery were categorized. Emergency surgery really meant life-threatening surgery. These patients needed to have had a COVID test on admission, but surgery was to proceed. In the acute surgical setting, a history was elicited, COVID-19 testing was carried out, a chest X-ray was performed, and if there was an acute abdomen and a CT abdomen was requested, then at the same sitting, a chest CT was done. And this, if you like, was to make sure that there were no respiratory involvement in the patients who had come in. And I'll allude to that in my talk later on. As far as urgent planned surgery was concerned, the patient was requested to self-isolate at home for a period of 14 days. They came into hospital and had a COVID test, and if they were negative, informed consent was obtained, which meant that they may have the opportunity in the hospital to become positive for COVID, and that may lead to adverse events. And only after they were told about all of these potential complications did the urgent planned surgery go ahead. The next group of patients who were considered high risk were patients where we found that aerosol generating procedures were being carried out. These include endoscopies, the ENT procedures, dental procedures, and anesthesia. So for these patients and the healthcare providers, full PPE was mandatory. Disposable gloves, fluid repellent gown, eye and face protection with FFP23 masks, and the practice of donning and taking off, doffing of the PPE in advance was taught to the healthcare personnel for the safety of the patient, and we sent out a mandate saying that laparoscopy should be carried out very carefully with deflation after the procedures, filters and traps for the suction devices, and to perform the procedure only if mandatory, because we wanted to make sure that there was adequate filtration in the operating rooms and in the endoscopy rooms. So ultimately, the fact was that we wanted safety first approach to protect staff and the patients. So the next aspect which was introduced were the prioritization surgical guidelines. Now the prioritization were in 4 levels, level 1 to level 4, but the level 1 was divided into A and B. Emergency were where surgical procedures were necessary within 24 hours. 1B was when it was urgent, with operative procedure to be carried out within 72 hours. The level 2 was where surgery could be deferred for up to 4 weeks. Level 3, where surgery could be delayed for greater than 3 months. And level 4, even further than 3 months. The planning strategy for the whole of the National Health Service in the country at the time was to allow the management to plan the reallocation of resources. Individual surgical specialties were cajoled, if you like, by the management, hospital management in each trust and in each university hospital to pool resources and to appreciate the needs of specialties where the surgical procedures were most needed. It also gave us a chance to facilitate the development of regional surgical networks to deliver surgery in a timely fashion, which meant that if there were hospitals with spare capacity in a non-COVID area, then the patients from one region could be transferred to that region for surgery to be carried out in a timely fashion, and that really meant cancer surgery. Now, what were the protocols of care in hospital when the patients were afflicted with COVID? The mild to moderate symptoms, which have been put on my slide here with fever, cough, gastrointestinal symptoms, musculoskeletal pain, and malaise. The initial prescription was for self-isolation at home, simple analgesia, and hydration, because the research or the evidence that was being collected so rapidly during this period in time showed that the viral load reduction happened within 72 hours in a majority of patients and up to 7 days. Now, if the fever had not abated within this period in time, then you seek the assistance of your GP through the NHS helplines for advice. And if the GP felt that you needed admitting, then you went to the accident and emergency department of the local hospital. Now, the severe patients with severe symptoms, acute breathlessness, unrelenting fever, and cough, they were admitted to a COVID assessment unit in most of the hospitals to decide the level of care, whether they could be monitored on the wards, offered supportive treatment, or whether they needed transfer to the intensive care. Initially, the treatment in the UK was mainly supportive because we didn't have any evidence that we could treat this COVID-19 because of no past experience. So mainly the patients were tested. If they deteriorated, they were transferred to the intensive care units for assessment and respiratory support. Now, the further response to the NHS was to now look at capacity building. So the NHS created what we call as Nightingale Hospitals. There were 4 initially created, one in London, Birmingham, Manchester, and in Glasgow. And these were put up in record times. We made arrangements for patients to be ventilated in these facilities. Procurement now was in good space. We had adequate PPE and ventilators. And in the main university and district general hospitals, we had designated areas. The COVID area, which was either called red or COVID-rich areas, and non-COVID areas, which were green or light areas, where patients could be separated. We had 2 emergency areas to receive patients with non-COVID and COVID afflicted patients. The working practices were changed rapidly. We were converted into designated teams. Virtual clinics came into play, virtual multidisciplinary team meetings, and every specialty, surgical specialty, was requested to look at the waiting list prioritization. Patients who were waiting for surgery, patients who were waiting for cancer surgery, the orthopedic, the cardiac, the whole surgical specialties were requested to sit together, prioritize the waiting lists into what I showed earlier on, so that the surgical procedures can still be carried on in spite of the COVID pandemic. So what were the lessons learned? Initially, as my previous colleague alluded, it was supportive treatment, and most patients who deteriorated went on to have intermittent positive pressure ventilation. They were treated with medical treatment with antimalarials, antibiotics, clarithromycin, antiviral, remdesivir, but really there wasn't any evidence built to suggest that any one of these things were helping. However, because of the abundance of information which was being passed around, many people decided to treat with supportive measures. However, in my own specialty in cardiothoracic surgery, what we learned very, very quickly that patients who came extremely ill, who were put on the ventilator, perished. And the mortality rates were extremely high. And we quickly learned that this was not acute respiratory distress syndrome, but this was microemboli in the vessels in the lungs. And when we found out that this was secondary to a cytokine storm, we realized very quickly, when I say very quickly, within 2 to 3 months, that there was endothelial dysfunction. And this endothelial dysfunction was prevalent across the systems. If it hit the respiratory system, you had acute respiratory failure. If it hit the cardiac muscle, you got a kind of pericarditis, a viral pericarditis, a viral myocarditis, and if you had incipient coronary artery disease, it caused problems with myocardial infarctions, arrhythmias, and therefore the prevalence of endothelial dysfunction was the cause of this multi-system failure. We had patients with strokes, we had patients with neurological symptoms which were mild, we had anxiety, delirium, hepatobiliary acute liver failures with terrible jaundice, musculoskeletal with patients who were in intense pain, gastrointestinal with diarrheas, and we also had a pediatric cohort where they had various system involvement, albeit I hasten to add a small percentage of patients. So, what was the next steps now that we were in a position to understand what was going on? Self-isolation, effective leadership, communication, and governance with this leadership, which was carried out quite well by the government, talks about lifting of lockdown, wearing of face covering, which had become mandatory outdoors, and new ways of working. So we decided that what we needed to do at this stage was to involve all of the institutions in clinical trials. Oxford, if you led the trials. And the recovery trial, which was in the vicinity of the Oxford group, recommended that dexamethasone given early reduced cytokine storm in the disease process. Now this, if you like, is a cheap drug, and giving it when the patients are not yet deteriorating is the treatment of choice. You don't want to give the patient when he has deteriorated and has got X-ray changes and is going to be needing respiratory support. So it's a fine line between recognizing a patient who's deteriorating and a patient who needs the medication. And the next important learning point was that we saw a lot of endothelial dysfunction and microemboli in the vasculature. So antithrombotics with heparin and enoxaparin were introduced, and immune-based therapy with plasma therapy was also, if you like, tried and tested, but the evidence was such that we do not now prescribe plasma therapy. It may well work on a case-by-case process. However, it is not a prescription in the United Kingdom at the present time. So what are we going to do now in the recovery phase? What are the criteria we need to fulfill? We need to make sure that we have theater and ICU capacity. We have had a lot of burnout. We've had, a staff shortages. So making sure that we have an availability of the entire team, equipment and drugs, and systems pathways, with infection prevention and control. All of these things are being done as a multidisciplinary approach with the Intensive Care Society, the Society of Anesthesia, the Royal College of Surgeons, the Federation of Specialist Surgical Associations. So this really has brought all of us together to treat this one disease or pandemic. So, the surgical prioritization pathway describes the level of surgical priority, but with the exception of obstetrics and gynecology and ophthalmology, which they have their own guidelines. And I've discussed the priority levels before. This is just to refresh that we still run the levels from 1 to 4. And what we've also done is to prioritize by risk. The risk factors identified are asthma and chronic lung disease, diabetes, cardiac conditions, chronic kidney disease, severe obesity, age greater than 65, and immunocompromised patients with cancer, transplant patients, and liver disease. Now, as far as the prioritization by recovery is concerned, we looked at the literature, and what we have come out with is a joint statement. And that joint statement is in my next slide. What is the size of our problem? How many patients were waiting for surgery before the pandemic? How many have since been added in the last 26 weeks, 6 months? How do we prioritize patients now? What resources are available locally to deliver surgery, especially high dependency unit beds and ITU beds? What state is our workforce in? How do we manage political, media, and public expectations? If I can just delve for a minute or two in the state of our workforce, we have acute shortages. We have had burnout, we've had mental health issues, and the medical personnel who have been afflicted with COVID have got long COVID syndromes. Now, the long COVID syndrome is something which is being looked at very carefully in a very large research trial from the University of Leicester, where we're looking at the after effects of COVID. The general practice, the College of General Practitioners have taken this on very seriously, because it's not just musculoskeletal pain, it's lethargy, it's changes secondary to the events in the respiratory tract, patients who in the ethnic minority group whose diabetic profiles have been exacerbated. So this is something which is ongoing. It will cause concern, and it's not going to be something that we will be getting over in the near future. So what have we done now? As of the last couple of months, we have increased the priority levels from level 1 to 4 to 5 and 6. Now, level 5, priority level 5, is when the patient himself requests to remain on the waiting list, but to do this only because their concerns regarding COVID-19 will be high, and the introduction will allow National Health Service, England, regions and trusts for including or excluding those patients listed as priority 5. They will remain visible and will be reviewed, but to make sure that their condition or preference has not changed. If I can give an example, somebody with gallbladder disease who was to receive a cholecystectomy has now been in remission. He's been treated with antibiotics and wishes to have his surgery, but not just yet, because on informed consent, he has been told that the chances of getting COVID while he is in hospital is high, and therefore wishes not to have his operative procedure just now. These patients, if you like, are parked and they still remain on a waiting list. As and when a opportunity is available for them to come into hospital, if they do not still wish to have the procedure at that time, then they are given the option of remaining on the waiting list or to leave and go see their general practitioner. This, if you like, is unique for the United Kingdom. Now, a priority level 6 are patients who have been offered 2 dates for treatment, as I illustrated just now, but have declined and still wish to remain on the waiting list. So the immediate future for surgery is that the waiting list review is to be completed. Monthly updates to the guide will be carried out until its time expired, and the clinical review of patients in every priority must continue, and we must reprioritize cases as necessary. So how has this pandemic changed the way we are in practicing surgery in the UK? The admissions to the hospitals are very, very carefully monitored. The hospitals have been divided into COVID and non-COVID areas. The non-COVID patients are categorized, as I said, surgically categorized. Surgical lists are still ongoing. The patients are then discharged home. They are seen virtually. Virtual clinics have flourished. Virtual MDTs are also flourishing. And what we need to see is what happens by way of feedback at a later time, whether this is going to be the new normal or whether we need to go back to where we were. So, as far as the post-COVID recovery is concerned, as I was alluding to just now, a rehabilitation service with the general practitioners and the physiotherapists are being carried out. An initial assessment is being done to make sure that these patients are not in a non-COVID syndrome situation. A 12 weeks personalized aftercare is provided, and regular follow-up by the primary care in general practice for at least a year. And this service includes medical personnel, nurses, physiotherapists, mental health, and peer support. And the largest trial which is being carried out is through the Leicester Biomedical Research Center, which is run by the National Institute for Health and Research. I acknowledge my talk to NHS England, to Mr. Nigel Mercer, who's the president of the FSSA, Professor Derek Alderson from the Royal College of Surgeons of England, Professor Michael Griffin and Professor Rowan Parks from RCS Edinburgh and the Surgical Specialist Associations. Thank you very much for your attention.
Thank you very much, Professor Rajesh. That was very educative. With the permission of both the speakers, I would like the matter to be thrown to the floor now. Can I request Dr. Mohan Vishwanathan to come up with any opinion or question if he has?
Thank you, madam. I've been listening to all the speakers and I've learned a lot, both the UK experience as well as the Indian experience. And quite honestly, I knew more about the UK experience than the Indian experience because I don't think I've seen many of the Indian publications, but the work being done at my alma mater, General Hospital, Government General Hospital and Madras Medical College is something amazing. And the number of cases treated with very low mortality is something which is very, very creditable. I'll make one or two comments and then I'll just make some comments. I really don't have any questions. So one of the things which has bugged us and we still don't have the answer is why was the mortality so low in India? I know that at the beginning of this epidemic, there were projections that there'll be millions and millions of deaths in India and there'll be no place to bury them and there'll be all the crematoriums will be full and all kinds of things are projected, even by some of the international experts. But that was not the case. And the actual number of cases which are treated could be an underestimate because many of them are asymptomatic, as we know. But the number of deaths certainly cannot be a gross underestimation. Where are the dead bodies? In fact, in the state of Kerala, and I'm sure the same will be true in Tamil Nadu as well, in Kerala, they did a count of how many people died during the COVID year, totally, all deaths. And compared to the previous year, there are actually less number of deaths overall in Kerala during the COVID year because all other deaths came down. So actually, there's not been such a high mortality, and it's actually much lower than what is reported in even the UK or US and so on. Many theories, they say due to BCG, they say because we have a younger age population, they say because it is we are exposed to so many other infections and therefore we have developed immunity. Many theories are there, but and maybe the strain is different, our genes are different, genetic variation. There are about 10 different theories which are put forward, but the fact remains that we have lower mortality. I don't think honestly it's because we treated patients in a different way because as we heard, we are only learning as we're going along with treatment. So we didn't have any special treatment here in India. So that's something worth studying. Why, in an international comparison, since you are here from the Royal College, and since Dr. Gopala presented such fantastic data from MMC and GH, I think it would be worth doing a kind of a comparison to see if they have blood stored and so on. Early in the disease, I did talk to some of my colleagues and say, please store sample because it's a golden opportunity which you'll never miss. But of course, they were overwhelmed with the cases and research was the last thing on their priority at that time. But that's something which is definitely worth studying for the future because COVID-19, heaven forbid, may not be the last of the epidemics and there could be something else coming. And the lessons we have learned from COVID-19 is something which, many of us have learned for the first time. And therefore, there are a lot of valuable lessons to be learned. Very interesting to see how each country has dealt with it in its own way because you have to act locally. Talking about my own specialty, Dr. Gopala beautifully summed up the relationship between diabetes and COVID-19. There's actually a bi-directional relationship, which means that diabetes can make COVID-19 worse because of the altered immune function. You can get more of cytokine storm, more severe disease, more mortality, more morbidity, and everything, more extensive disease as you get in tuberculosis and other diseases, but also vice versa. The COVID-19 makes diabetes worse. And we know that I know for sure that people who do not have diabetes suddenly develop diabetes. Now, whether it's due to the high doses of steroids which are given, because people did go overboard with giving the steroids in some cases, because life-saving was the most important thing. So it could be due to the steroid. In some of these cases reverted back after the steroid. It could be potentiation of pre-diabetic state into diabetes. Something was just waiting to trigger, and then comes the infection, plus the stress, plus the steroid, and then the milieu to develop diabetes. So that also we saw. We also saw that due to the lockdown, not due to COVID, but due to the lockdown, there was a lot of stress, frustration, depression, anxiety, which led to diabetes. And of course, due to the lockdown, because of people not being able to go out to walk, and sometimes even the diet going out of order, many put on weight. Obesity rates really increased, and that's definitely a trigger for diabetes. Dr. Gopala also mentioned about the about the COVID-induced diabetes, direct injury into the pancreas. I'm part of an international group which is studying this. From the UK also we have, from the Imperial College, we have a group, and from Australia and from India, we've all joined together, and every new case of COVID-induced diabetes, what we think is COVID-induced diabetes, is now put into an international registry, and we are trying to look at it. We don't have the answers yet. We have about 400, 500 cases already in that of pure COVID-induced diabetes, what we think as some criteria for that. But we're not able to really say whether it has affected the beta cells directly. In other words, the virus went and knocked out the beta cells like type 1 diabetes gets precipitated. That kind of a thing we are not able to see. More of the type 2 variety we are seeing. A few cases of type 1 have been picked up during this period, but it's still very early days to say whether really specifically due to COVID, there is an entity called as COVID-induced diabetes. It's very early to say. The other thing that COVID taught us is that while COVID-19 kind of swept the whole, country, under the carpet and everyone was running helter-skelter, many people forgot about non-communicable diseases. And non-communicable, in every presentation, diabetes and hypertension come right on top. But the very treatment of these diseases, including cancers, including chronic dialysis that was done, treatment, chemotherapy, routine treatment of diabetes, hypertension, and heart disease, all went for a 6 because the clinics were not working. People were scared to come. And therefore, a precipitation of diabetes and a worsening of some of the diabetic complications, including, very sadly, I lost some patients because they didn't come with diabetic foot. Even after sending pictures and saying, this is an emergency, you have to come. No, if I come, I'll get COVID. And finally, they died due to the diabetic foot infection, not due to the COVID. So this is a kind of fear. And so the importance of non-communicable disease actually came out after COVID-19, that non-communicable disease will get worse due to COVID, and COVID will make the non-communicable disease worse. So we should not forget that while COVID may come and go, the NCDs are killing many, many more people. If you take India's statistics and if you compare the number of people who die every year due to diabetes or hypertension, it's several fold higher than the entire COVID deaths in India. 1.5 lakh people died due to COVID in the whole country, whereas at least 5 to 6 lakh people die due to diabetes every year. And that's not going to go away. It's going to increase. So I think as a diabetologist, without any bias in my specialty, we should say that control of the non-communicable diseases like diabetes and hypertension must be done, whether we have COVID or we don't have COVID. And if they're really under good control, my patients have done well. Thousands of my patients who had COVID escaped because their A1Cs were under control. We found a cut point of A1C around 8.6 or so being the threshold for people to do badly and for people to recover. So as long as it's a message that I give as a diabetologist, keep your sugar under control, so that even if you get COVID or get anything else, you're going to be like anybody else, and therefore your death rates will come down. So thank you for inviting me to be part of this. I've learned a lot from this meeting, and I hope that Dr. Gopala mentioned some papers are published. I would love to read those papers, but we should get our papers into international journals so that the world knows how India treated this, because with very limited facilities, you have done a fantastic job. Dr. Ranjit, I also listened to your presentation, and very nice to see how down south with such little facilities, you were able to do such great work. So congratulations to the whole team. I think the whole country has rallied together, and I salute all the COVID warriors who have done such a great job. I'll rest here. Thank you.
Thank you,
Thank you,
Dr.
Dr.
Mohan. Thank you. Before we proceed further, some information on the research, the ongoing research projects, and so on. Let me request Dr. Ganapati from E-Road. Now, Dr. Ganapati is in a town which is on the western part of Tamil Nadu, and how was the situation there, Dr. Ganapati? How many cases did you encounter, and what is your experience?
No, as everyone mentioned, we had so many COVID infections, and our nearby hospital was, government hospital was E-Road Medical College, which was previously called Perundurai Medical College. We used to send, and certain within private hospitals, they were dealing with the COVID. But as already Dr. Gopala has enumerated everything about COVID. But as a critical care man, certain things, what I would like to say is, suppose what were you doing for, suppose if the COVID patients became bad, what were the protocols of CPR we have taken in our government hospitals, sir? For CPR for a COVID patient, do we take any special precautions, or do we have any aerosol isolated rooms in our Rajiv Gandhi Hospital?
Dr. Gopala Krishna, would you take that question, please?
sir. Actually, all the critically ill patients are kept in intensive care units, and all the personnel who are
Yes, sir.
attending the unit, of all the cadres, they are wearing the protective equipments, PPEs. So they are treated like any other patient. Particularly the young patients, we just omit any of the measures. And there are instances where we have done even intubation, ventilation, and successfully they have come out also. So we haven't differentiated really the way we approached a critically ill patient, whether it's COVID or non-COVID. I agree, in the initial couple of months, there was a lot of fear among the people who were on the front line. But from July, after July, August, and so on, once they got empowered with how to handle. And one more thing I forgot to tell is that yet another strategy, we delivered 30 consecutive days, we delivered web lectures, sensitizing on the treatment protocols. All the the young doctors, well, some of them in quarantine in hotel, and some of them at home, some of them on duty, and all that, they kept on attending, listening to this. That one step really made a lot of difference.
No. Thank you, sir. And further, what I would like to insist is, instead of, because as a critical care man, I would like to enlighten, instead of using a direct laryngoscope, we were using this video laryngoscope with the protection. So it was very useful. And another thing is, I think it is a bit, the standard is so high. Instead of doing CT, nowadays we use lung scan, which is very cheap. And we are it is very easier for us to easily grade the stages of COVID, and which has come in so many journals. So it is very cheap, and immediately we can diagnose. This is what I would like to mention, because as a critical care person, while we deal with the emergency patient, I would just to maintain the point. Thank you, sir. Thank you very much. And I thank the VC for giving me opportunity also.
Thank you, Dr. Ganapathy. Dr. Ravi from Coimbatore. Dr. Ravi, do you have anything to say? Dr. T.K. Ravi?
Yes, to unmute.
Yeah, I find Dr. Sai Krishna. Dr. Sai Krishna, would you want to add something, or you have a question?
Yeah, I would be honored if I could ask a couple of questions to both the eminent speakers. Of course, many thanks for Dr. Ranjit Jayasekharan for showing what a pioneering work is done down south. A couple of questions first to Dr. Gopala Krishnan, sir. Good afternoon, sir. I really enjoyed the talk. As a MMC and myself, it gives me a lot of pride that our hospital has done such yeoman service, sir. The first question I just wanted to ask is, you mentioned that the COVID virus attaches itself to the ACE receptors on the cell surface. How safe is it for a patient with hypertension to have ACE inhibitors or ARB drugs both in a COVID and non-COVID patients, sir?
Initially, there was a lot of debate on this particular issue. In fact, for the first 1 month, many people even discontinued ACE inhibitor or ARBs. And then later on, after a concerted discussion among all the expert groups across the globe, all academic bodies have come out with a guideline clearly saying that those who have already been on either ACE inhibitor or ARB can go ahead continuing the medications. No need to stop just because they have contracted COVID-19. That has been made very clear. It is absolutely safe.
The next question I have, sir, I know we are in the process of vaccination, and I know the healthcare personnel have been given priority over vaccination. Many of us have had 2 doses of vaccine. Some of our doctor colleagues, especially our junior colleagues, think that once you had your 2 doses, it's all hunky-dory. And I think the message should be that we should still follow precautions, same the social distancing as well as hand sanitization, because I know a couple of doctors who had 2 doses have got COVID after the 2nd dose. Your views and your advice.
So no vaccine can be 100% safe and protective. That is normal. Even the published literature says that efficacy is up to maximum 85% for vaccine and so on. And number 2, how long the protection will last. That's a big question mark. And number three, we haven't yet devised a kind of a robust mechanism to find out what is the protection level. For instance, among the assays for the antibodies, development of antibodies after vaccination itself, there is a lot of research. I mean, overall, the titer of IgG and specific anti-S antibody and so on. A lot of confusion in that. Little uncertainties in that. And third thing is that even a person who has not demonstrated the presence of protective antibodies, still there can be protective cell-mediated immunity. So the research on the response to vaccination itself is a big area, big chapter. But we really don't know, even if somebody has developed a kind of a protection, how long it is going to last. So I think this pandemic is not over yet. There is no room for complacency, and there is a big question mark whether these vaccines will be really able to successfully tackle the variants and the variants of the virus that are going to emerge. Already some of them have emerged and so on. So we have to maintain the COVID appropriate behavior as of now.
Dr. Sai Krishna, I think at this point I would like to kind of insinuate two questions which have come in. Part of it is already answered by Dr. Gopala Krishnan. The Omayal Achi College of Nursing and Dr. Ashok Kumar from Coimbatore had come out with these questions. Will people have to get COVID vaccine every year like influenza vaccine? And what is the efficacy rate of these vaccines to mutated forms? I think these questions have already been answered by Dr. Gopala Krishnan, and we don't have to go further into it. And before we go to your next question, Dr. Sai Krishna, something related, because this discussion came up, I'm throwing this question which was posted by Dr. Hariharan quite early in this webinar. What are the complications of administering COVID-19 vaccines on patients taking medicines for mental health issues? Dr. Gopalakrishnan, has there been any study on such thing? I think we are too early in the vaccination program to have these questions answered. Okay, as of now, it is not a contraindication.
Vaccination for anyone and everyone, but for certain categories. One, children less than 18 years, pregnancy, those who have very severe allergic phenomena.
I think Dr. Ravi is there. Dr. Ravi, would you want to join, or can we continue with Dr. Sai Krishna?
Yes, madam. Can you hear me, madam?
Yes, we can. Please proceed.
Hello?
Yes,
Yeah.
please proceed.
In fact, really, Dr. Gopalakrishnan's information was quite useful, and the teamwork which they have done, it was laudable, especially for the state of Tamil Nadu. And scientifically valid data he has got from the hospital, which causes more morbidity and all those things. Further, in which direction you would like to move, sir? Because there may be an expected second wave possible. Hope it will not. So what kind of measures to be taken?
Now the challenge is twofold. One, continuing to be keep a close vigil on the COVID patients. Even now we have about 90 patients, positive patients, some of them are pretty sick. Simultaneously taking care of non-COVID regular work which has bounced on us. Like many issues have been kept pending for more than 9 months and so on. So our regular work has doubled. Third thing is that the mental fatigue that has set in among the workforce to continue to do COVID work. It's not easy wearing a PPE. I salute all my junior colleagues wearing a PPE for these continuous hours and not going home for a couple of weeks. 1 week they'll be on duty, 1 week they'll be in quarantine in a hotel. So it is a huge challenge they all have done. So we have to keep a close vigil on COVID as well as we should be taking care of non-COVID. But one thing we are certain is that now we know fairly better how to handle this. We are in a position even to anticipate complications. That is expertise. That is the advantage of working in a big institution. So we have got a huge human resource. We learn from one another, and we have got a nice leadership who can just collate the workforce in a nice way. So, and there are beautiful mechanisms of exchange of information and updating ourselves and so on. With our experience, we are even able to predict who is going to land in trouble based on the parameters, the clinical parameters and laboratory parameters. And thanks to the laboratory sciences departments, be it pathology, biochemistry, and radiology, and virology, we are able to get all the profile within a couple of hours. So combining the clinical parameters, clinical assessment and the laboratory parameters, we are fairly confident of handling any severe, serious problem right now. And as I've already said, we keep the treatment protocol, the standardized protocol as a fulcrum, but we know where to violate and where to apply a particular medication, a particular intervention in a given situation. So that is the advantage of having gained some expertise over the past 9 months.
And one more important thing I would like to have, sir, that is, you might have seen patients who have already taken some herbal medicines, Siddha, Ayurveda and all. In what level it has either had any positive effect? Any study on that, sir? It has been done?
No, unfortunately,
some
no
information
study
on that
has been published so far. I mean, studies are on, many studies, even Dr. M.G.R. Medical University has embarked on a study. Still, the results have not been published yet, so I am not in a position to talk about it. So coming to, just one point I forgot, I mean, from UK experience, they mentioned about children. In fact, I had a slide, I just forgot to project that one. Great work has been done in Institute of Child Health. We thought children are totally spared of COVID. Of course, in a way, it is true that children are less affected, but unfortunately, some children who get the disease, they land in a severe kind of a hyperinflammation syndrome. That can vary from very mild febrile illness even up to death. About 75 children in ICH and more, they developed a Kawasaki phenotype of hyperinflammation syndrome with demonstrated involvement of the coronary arteries, coronary artery dilatation that can kill. So fortunately, we had the expertise, and thanks to government, we were able to procure human normal immunoglobulin, very expensive, and a combination of steroid and aspirin, heparin, and human normal immunoglobulin, and most of the children recovered well. Initially, there were few deaths, and that was totally different kind of experience in pediatric side. The Kawasaki phenotype of hyperinflammation syndrome following COVID.
Excellent presentation by all our speakers, sir. Thank you, madam, for arranging such a beautiful webinar program for all our students and scholars. Thank you, madam.
Thank you. I find Velamal Hospital, Dr. Chandrasekharan and others, I'm sorry, Dr. Gerald and others from Velamal and Dr. Celestin Raj from Coimbatore in the audience. Can I request Dr. Gerald to give us his opinion or experience?
Yes, madam. Good evening, madam. Thanks for the opportunity to participate in this webinar. First of all, I convey my sincere thanks for all the speakers. We learned a lot about the COVID. Our experiences, we have treated 1,210 patients totally, and we say that our death rate is around